Welcome, everyone. We will get started in just a minute.
Hey guys, good to see you.
Hey, Bettina, good to see you as well. Got a good crowd here for the showcase today. A lot of interest in these papers. Patrick's been
It's
fielding a lot of like, hey, sign me up. I want to attend.
it's such a feel-good moment to see all this work in one place together and like all this growth and recovery science. It's awesome.
Yeah, yeah. Well, and to see like how many people were able, how many authors were able to volunteer to, we thought maybe we'd have like five or six like raise their hand, but we got a lot raising their hand, so this is awesome.
Agreed, agreed.
And y'all, as we're logging in, if people want to share in the chat, like Patrick gave an example, but where you're coming from or anything else important about your role or yourself, that'd be great. So if we can do that, folks want to do that in the chat. Um, and we are recording today, and we will be sending the recording, a link to the recording out to everyone who has signed up for the showcase series. So if by chance someone forwarded you the link and you want to get on that on the invite, then pop your email in the chat. And Keone and Danielle have joined us today to make sure we have a little extra logistics support, so we can grab that and get you on the list to receive the link if you want. Yeah, and welcome everyone. I believe this is actually the 30th CoARS showcase. So very exciting milestone. Yay, Patrick, for all that work along the way. And this one is going to be a little bit different than our other showcases. So I am going to jump right in. As people are logging in, I'm going to introduce myself and the co-editors of the special issue that CoARS helped put together. So I'm Ashley Shadon. I'm from the Lighthouse Institute of Chestnut Health Systems, and I help lead the Jeep initiative, and I am a co-I on Cheer. Both of those are CoARS projects, which we're not here to talk about those today, but I can tell you more if you want in the chat, just ask. There are a couple of opportunities that Cheer and other colleagues want to share. So those can be placed in the chat. Because we have a jam-packed schedule today. This is an open forum, and as Aaron Hogue has said, it's sort of the town square of CoARS. So everyone, feel free to share any opportunities that you have. But I know that there were a few that Cheer wanted to get out there. So for the special issue, myself and Bettina Hepner, Rob Pack, and Jay Unick, and also Kenneth Bloom co-edited the special issue in Frontiers that focused on recovery science. And we've published an editorial summarizing the special issue and organizing the papers into themes. But we had a total of 24 papers published. And that is the largest single collection of recovery science focused papers, and it covers numerous themes in recovery science. So very exciting to see this. There's an author here from 22 of the 24 papers who volunteered to come here today and showcase this wide range of papers. So the goal isn't to give you in-depth details, but really it's to whet your appetite for the papers so that you'll go on and read them and get excited about this special issue. So it is going to be a little bit of a rapid fire. This is not like our usual CoAR showcases sessions. Usually we have one team is presenting a topic, and then we have time for a lot of two-way discussion going on. So that's our typical CoAR showcase. But since we only have an hour and we had so many authors who were able to come today, each presenter is only going to have 2 minutes to highlight their paper. So it's a little bit like speed dating, to get you jazzed about going and reading their paper. We aren't going to have time for our normal Q&A today, but feel free to drop any questions in the chat and include the paper or the person's name you're asking about, and we'll try to make sure that it gets to authors. And include your email address if you want to connect with a presenting author offline, and we'll try to make sure that that all happens. We're also wondering if there might be interest in future showcases of some kind of diving more in depth into some of the themes. So if there are thoughts you have about that, pop that into the chat, and we will record that and be responsive to that. And in the interest of time, I'm going to get us rolling. And apologies in advance if I cut you off. We're trying to keep to a schedule. So we're going to start with some of the papers. Danielle's going to share her screen because we have the title and authors listed on the screen so that we don't have to spend time reading those. You can see those on the screen yourself. Um, and we'll start with some of the papers that are in our first theme, which is recovery community centers. And Danielle, are you able to share your screen with us to get going?
Are you able to see it right now?
Mm, oh, you know what? I don't have it. Thank you. The first paper up, thank you. I was on the wrong view here. So we can get to the next slide and have our first paper with Hannah is up.
Hi. Yeah, can you guys hear me okay?
Yeah.
Okay, great. So since I'm the first, I'll just give like a quick primer on what a recovery community center is. So these are community centers, usually like that serve a relatively small geographic range, like a city or county, that can provide a wide range of support services to those in recovery. So this could be um, facilitating peer recovery, coaching, social events, job assistance. And prior research has found that being affiliated with an RCC generally predicts positive recovery outcomes. But of course, as the old adage goes, recovery happens one day at a time. So in this study, we employed a daily diary approach to assess whether the self-reported helpfulness of RCC experiences on days that they're visited varies from day to day. And then if that helpfulness then predicts variation in meaningfulness and recovery from day to day. So we had 94 participants in our study, and they were all affiliated with RCCs, and they took daily surveys on their smartphones every day for 10 days and reported on both their RCC experiences that day, as well as their general recovery experiences and emotions that day. Ultimately, across all reported days, RCCs were visited 31% of the study days, and half of the variation in the helpfulness that the individuals reported they received that day was attributed to within-person differences rather than between people. So this means that even for the same individual, one visit to the RCC may be particularly helpful, while the next one is comparatively more or less helpful. And on days which participants reported that their RCC visits were particularly helpful comparative to their personal mean, they also reported that they experienced a higher sense of meaningfulness and recovery identity. So these findings offer some preliminary evidence that RCCs help bolster recovery outcomes, not just for the whole individual that is affiliated with the RCC, but also helps predict recovery outcomes in a temporal fashion and helps attendees build their recovery one day at a time.
Thanks, Hannah. And we'll pop over to Deodora.
Thank you. Good afternoon, everyone. So I'm excited to share our study. And what motivated us to explore this analysis stemmed from our understanding of past and current disparities that exist. We know that racial and ethnic disparities in substance use disorder treatment and recovery outcomes have persisted across the United States, with Black and Hispanic/Latino individuals and communities facing higher overdose rates and more barriers to accessing medication for opioid use disorder, and also lower levels in treatment retention as well. So in this context, RCCs represent an important community-based approach, but until now, we knew very little about whether these centers operate differently across racial and ethnic communities. So to explore that, in this study, we analyzed national survey data from 122 RCC directors across the US. We categorized these centers based on the racial and ethnic makeup of the zip codes that they served. So we identified those serving predominantly Black, Hispanic/Latino, or other communities, which were predominantly white communities. And then we compared their services, linkages to clinical care, and attitudes towards medication for opioid use disorder. And surprisingly, we observed remarkable consistency across all groups, considering the range of services, linkages, and care models. And in both cases, participant demographics closely mirrored the racial and ethnic composition of their surrounding areas, suggesting that RCCs are reaching their intended communities. And we did find two meaningful differences. The first being that RCCs serving Hispanic/Latino Latinx communities we're less likely to offer 12-step groups. And the second being that those serving Black communities, we're more likely to have direct partnerships with clinical sites that provide medication for opioid use disorder. So overall, we believe these findings suggest that RCCs may be helpful in closing some of the longstanding equity gaps in recovery support, and may not only be a cornerstone of community recovery, but also a pathway or bridge towards more equitable recovery systems nationwide.
Thanks. And we'll pop over to Bettina for the next two papers.
Perfect. Thank you. Hannah, thank you so much for setting the stage for us about what RCCs are. That's very helpful for us. And I'm going to be talking about two papers today, and I wanted to give a framework, but our goal is to build towards effectiveness testing of recovery community centers. And that's, of course, incredibly challenging because recovery community centers are very diverse in the kinds of services and supports they give, as well as how they do that. They really match to the community in which they exist and which they serve. So tackling this issue of how do you study effectiveness has opened many questions for us. And in this paper here about the linkage between opioid treatment programs and recovery community centers, we decided to take a step back from saying we can't test RCCs, they're open to the public. We can't randomize people to see it or not see it. But what we can do is we can study linkage to recovery community centers. And if it would be effective in terms of supporting recovery, if people would refer to RCCs as a standard of care. And we targeted opioid treatment programs, and we wanted to know, does this already happen? Do opioid treatment programs already know about RCCs, already make referrals, and how does that look like? So we identified a number of opioid treatment programs, and we focused specifically on OTPs that are within a short distance of RCCs serving Black communities. And then we asked them, do you know about RCCs? Do you know about mutual help? Do you refer? Long story short, we did find that referral to 12-step happens 100% of the times, and it happens much less commonly for recovery community centers, which there was a lack of knowledge, partially of it. But then even when we asked then, there's actually an RCC down the street from you. So you told us in general you're referring to RCCs. Do you know this particular one? And then the percentage went down again. And then we asked, do you tell all of your patients about them? And again, the percentage went down to only telling some of the participants and patients about RCCs. The paper is interesting in terms of exploring some barriers and food for thought about how we might improve those things. In the next paper, we tackled the same issue from a different perspective. The idea is, how do we measure effectiveness on recovery? And we're not testing a clinical model, and we are not saying that effectiveness of RCC could possibly be measured by folks obtaining abstinence and staying abstinent. It's a much more multifaceted topic. So we asked recovery community center directors, the same directors that Diadora was talking about. That was the same study. And we said, you guys are providing these services. You know what you're trying to achieve. We have some ideas about some kind of scales that may or might hit the mark. You tell us, do these scales work in terms of validly that people would show improvement on them? And would they show them over a period of time where we could measure them? And we collected a number of process as well as outcome scales that we threw together in our paper. And we also gave some feedback around that. We discussed the feedback we got from RCCs, and we also discussed that, of course, RCCs are not just serving the patients or participants rather that walk through their doors. They also serve an incredibly important role in the community, and that's something that's beyond what we are measuring in the scales we presented to them, but that's an incredibly important piece of RCCs as well. So I recommend you read the paper for all the pieces around and discussion pieces, and I'd love any conversation. So reach out to me over email for further discussion.
Thank you. All right, now we'll go to the second theme that we sort of grouped some papers under, and that was for peer recovery support services and that workforce. And with the first paper coming up with Tess.
Hi, everyone. Nice to see you all today. Thank you for having me. So this paper was authored by a group of 15 amazing scholars, many of which are here on this call. And we realized that the field really needed a more practical type of paper that reviewed strategies for supporting the linkage facilitation workforce, specifically for those supporting people with opioid use disorders. So for those who may not be familiar with this term, linkage facilitators are people who provide service linkage or linkage to care. So this can encompass a range of services to help people access appropriate treatment, harm reduction, and support interventions, maintain medication and treatment adherence, and obtain resources that assist immediate and long-term recovery goals. Linkage facilitators may or may not have direct lived experience, and it does encompass such job titles as peer worker and community health workers. So the expert authors conducted a narrative review, and in the paper we describe what we found is essential for supporting linkage facilitators. These are things like adequate pay and career advancement opportunities, robust supervision, comprehensive training and continuing education, establishing role clarification. And then we had 5 key recommendations for helping to support and advance this work, which you can read more about in our paper. So thank you for the time.
Awesome.
And
Thank you. And next up, I think we have Ryan
Hello,
or Angela. Sorry. Are we out of order?
That's
I can go.
okay.
I think this one's mine.
Okay. Sorry,
Yeah.
Angela.
No
I skipped
worries.
over in my notes. I apologize. Angela's
No
up
worries.
next.
Thank you. All right. So the primary research question or motivation driving this study was to better understand why peer support works, for whom, and in what setting or stage of change it is most effective. So essentially, we're looking to find what is the secret sauce inherent in peer support, and how can this be disseminated at scale for improved population level outcomes among persons with SUD. So while this body of peer support research is growing, specifically in healthcare settings, overall understanding is still limited, due in part to highly variant job titles, service activities, and work settings. So this study expanded a previous survey of peers in Central Appalachia, focusing on the identification of common work activities or interventions that peers perform, stratified by employer and intervention delivery setting within regional service networks, or we're also calling them recovery ecosystems. So knowing that effective delivery of peer support has implications across service settings, because we know that peers work around the recovery ecosystem and not just within the kind of confines of their employment agency. So this mixed method study began with a qualitative and methodological review of the previous survey by 8 subject matter experts with lived experience of substance use disorder. The improved survey was then disseminated in 9 states. 659 peers responded, indicating that they perform an average of 24 different activities on a regular basis, and that these work activities are often performed in communities and neighborhoods, client homes, and recovery community organizations. So similar to the preliminary study, survey participants reported spending about half of their time providing emotional support as defined by SAMHSA. So the next steps will include a national survey of peers to validate these findings, resulting in a formal index of PSS work settings and activities by employer type, and will also include recommendations for measurement. Thanks.
Fantastic. And sorry, I cut you off earlier, Ryan. Now you're up.
Hello, everyone. Good afternoon. Good morning. So for this paper, our motivation of our team was to introduce a framework for research and evaluation that would consistently clarify the roles, functions, and activities of peer recovery support specialists as they are proliferating and expanding across the world. We used a Delphi-like process that allowed us to engage with peers and other experts through the CoARS Peer Recovery Support Specialist Interest Group. The process we used was an iterative expert consensus approach to create a taxonomy. And a taxonomy is defined as a structured classification system that organizes information into categories based on shared characteristics, simplifying complex data for analysis and understanding. So the taxonomy that we derived based on this process has 6 primary taxons, which include lived experience, training, support approach, support settings, support activities, and recovery milestones. Each taxon has branches and sub-branches that provide a structured framework for understanding and measuring the effectiveness of these various aspects of peer recovery support specialists' interventions in a given system. And the core takeaway from this paper is that we believe we've established at least a first attempt at a standardized language and classification system that facilitates consistent evaluation and implementation of peer support across diverse settings. And we invite future empirical studies to use this taxonomy to operationalize various aspects of peer recovery support services.
Awesome. All right. And next up, we have Sierra, I believe, is presenting on this one.
That's right. Dr. Bell is stuck in travel limbo, so I'll be presenting on his and our co-authors' behalf today, sharing about our recent scoping review focused on the workforce outcomes of peer recovery specialists. So despite growing investment in peer-delivered services, there's been limited attention to the well-being and satisfaction and sustainability of the workforce. Our review synthesized 20 studies that looked at peer workforce outcomes like job satisfaction, burnout, retention, and then some contributing organizational and individual factors. Overall, the literature paints a mixed picture. On one hand, peers find their roles deeply meaningful and derive personal and professional growth from their work. But on the other, they face persistent challenges: inadequate compensation, lack of career advancement, limited supervision, and unclear role expectations. These conditions contribute to high emotional labor, blurred boundaries, and in some cases, burnout, especially when the organizational support is weak. The takeaway is clear. If we're serious about integrating peers into the SUD treatment continuum, we need to address these structural barriers. That includes improving compensation, investing in professional development, and developing interventions to support peer well-being. Peers want to stay in the field. They just need the systems around them to make that a viable choice. We see an urgent need for longitudinal research, better definitions of work contexts, and co-designed interventions that reflect peers' lived realities. And I'm going to share Dr. Bell's direct email and the paper link again if you'd like to learn more. Thank you.
Thanks. There's so many times I want to say amen to stuff. All right, our next theme is recovery housing. And the first paper up on recovery housing, Amy Miracle is going to present about.
Hi, folks. I'm Amy Miracle, and on behalf of the co-authors on the iStar team, I'm happy to tell you about our paper. We have several co-authors in this meeting, so if you guys wouldn't mind, and if you haven't already, please introduce yourselves into the chat. iStar stands for Infrastructure for Studying Treatment and Addiction Recovery Residences, and the iStar project aims to develop infrastructure to advance science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder, or MOUD. So why is this topic important? So we know that safe and stable housing is increasingly recognized as critical to recovery from alcohol and drug abuse, but research on the outcomes of residents in recovery from opioid use disorder, particularly those prescribed MOUD, is limited. So this paper presents results from an informal survey and discussion with 15 members of the iStar Advisory Board regarding priorities for research and training to inform recovery housing for individuals prescribed MOUD. So the advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Importantly, advisory board members include individuals with lived experience in recovery. So drawing on the advisory board input, we provide a roadmap to establish an evidence base on recovery housing for those prescribed MOUD, identifying ranked priorities of research and training topics for both researchers and recovery housing providers. And what were some key takeaways or the implications from the findings of this work? First, research on the effectiveness of recovery housing for individuals prescribed MOUD is definitely needed. But so is research that will help along the way, such as research on barriers to accessing recovery housing among those taking MOUD, as well as factors that facilitate supporting those on MOUD in recovery housing. So this paper also highlights that a number of pilot studies addressing these topics are currently being supported by the iStar project. Second, researchers and recovery housing providers would benefit from training on how to provide MOUD-supported recovery housing and how to study it. And the iStar training series provides training webinars for both researchers and operators to address common challenges. And these webinars were developed by leaders in the field and can be accessed on the iStar website. And finally, the research landscape is dynamic, as should be the priorities needed to fill gaps within it. The iStar Advisory Board meets twice annually and revisits this research roadmap to ensure what's posted on the iStar website is useful, current, and guides pilot studies and is up to date with respect to the research. So feel free to reach out to me or any of the co-authors to hear more about this paper or the iStar project and its training and research priorities. Thank you.
Thank you. Moving on to Patrick next.
Yeah, this is great, y'all. I'm just gonna dive right in. We did as part of the Jeep initiative. If you're not familiar, please check out the Jeep initiative website. We worked with 3 different community boards to develop a set of research priorities for recovery support services. And within that process, long drawn out process, we have an entire toolkit on that kind of stuff. Again, visit the Jeep website. But one of the topics was recovery housing and recovery residences. And what we did was we used a scoping study to ask the literature, have these questions been answered? We know on the ground people, was just as involved people in recovery, young adults in recovery, and peers and providers. And so if they're asking these questions, has the literature answered them? So we did a scoping study, and it's kind of a mixed bag. Some of them are answered, some are not. At the end of the day, as Amy actually just said, right, recovery support services are dynamic, and so it's really difficult to get to some static set of best practices, right? And so we found some areas where best practices are kind of universal and things that we should think about when developing recovery housing. We also recommended some areas for research that were not answered, as well as some areas where we just need to do a better job of translating in order to get that research out to the field to the people who need it. So again, read the paper, visit the Jeep website. We'd love, and email me all that stuff. End of the
Thanks. And moving on to Niles.
Hello, my name is Niles. Thanks to Amy and Patrick and others for defining MOUD and recovery residences. While these homes offer a safe and supportive environment for people in recovery, there's a critical gap in research and policy surrounding how to sustain recovery homes, especially homes that accept and support residents who take MOUD as part of their recovery journey because they've been historically excluded from many recovery settings. We conducted thematic analysis of interviews with 29 staff and operators from 10 recovery homes across the state of Texas, all part of Project Homes. And our interviews focused on funding strategies, partnership development, and long-term operational planning. We found that operators rely on a blend of grants, donations, and strategic partnerships, such as health clinics, partnerships with health clinics or social services to keep their doors open. And many planned to start charging rent when grants expired. But the operators who ran those recovery homes were concerned that charging rent would reduce access for low-income and marginalized residents. The key takeaway of our research is that no single funding stream is enough for operators. They're adapting by blending resources, leveraging partnerships, and obtaining professional certifications and staying flexible, but the path to sustainability is precarious for them. This matters because recovery homes are a vital piece of the public health response to the opioid crisis. And if we want to assist them in serving diverse and high needs populations, we need to build recovery homes on more stable ground. The first implication of our research and for practice is that funders and certifiers need to invest both in stable funding and in technical assistance for recovery residents, staff, and operators. Second, policymakers must recognize and address the true cost of operating recovery homes with quality and equity. And third, operators themselves need support to creatively adapt their models using local resources and professional networks. A next step for research is to evaluate which sustainability strategies work best for recovery homes who serve underserved communities, and how healthcare systems can better integrate with recovery housing to improve equity and outcomes. Thanks so much. Read our paper, and we've got some great coverage on the UC Berkeley website, which I've linked in the chat.
Awesome. All right. Now we have a group of papers. We had some that focused on recovery processes and recovery identity. So we'll get started with Lauren. Oh, no, I'm sorry. I messed up again. We got one more in this grouping.
One
and Amy
more
is going to step
recovery
in
housing
again.
paper.
Sorry, I thought we were ahead, but now we're behind.
No worries, no worries. So Amy Miracle again, but presenting this paper on behalf of Jody Dewey and other co-authors. And Jody's work presents findings from her ISTAR funded pilot study, which spawned this paper and 2 other papers, one published in the journal Justice Opportunities in Rehabilitation, and another just recently published in the Journal of Substance Use and Addiction Treatment. So her paper is focusing on criminal legal system involved residents in recovery housing and why is this topic important. So we've already heard about how important recovery housing can be in general, but it may be particularly helpful in supporting recovery and reintegration for CLS involved individuals. So despite promising findings regarding employment outcomes, reduced recidivism, and remaining substance free, more research across the different recovery resident spectrum is needed to identify the key elements that contribute to their success. And this paper highlights findings from qualitative interviews with 19 staff members in 4 level 3 recovery homes in the Chicago area that serve CLS involved residents receiving MOUD. And it focused on the factors that are essential to supporting them in their recovery. What were some of the key takeaways from this work? Jody found that through programming, staff provides skills-based education to guide residents towards gradual independence, aimed at destigmatizing CLS-involved residents and assisting in their reintegration. Importantly, it highlighted that wing leaders, her term, use their own lived experience to help CLS-involved residents achieve sobriety and social stability within these kinds of environments. However, she also found that the effectiveness of support may be limited for those receiving MOUD, as staff in this study did not actively encourage discussions about MOUD and recovery. And she worried that this omission is potentially important because it reinforces stigma and hinders authentic relationships required for social model recovery. So please feel free to reach out to me or to Jody to hear more about this paper or other findings from her ISTAR pilot study. Thank you.
Thanks. And now we'll jump over to Lauren with our next theme here in recovery processes and identity.
Hi, everybody. This is one of my dissertation papers. So I looked at the dualistic model of passion, which essentially says that people who have a passion, such as like riding a bike or art or reading, and it's like well integrated into who they are as a person and the other identities that they hold, they have higher life satisfaction and like less depression, less anxiety, things like that. So I wanted to look at this in a group of people in recovery to see if having a passion that is this kind of well-balanced passion would help people in recovery. So at first I just ran some t-tests and then I did a regression, and essentially what I found is that it is true. So people who have a passion, again, such as riding your bike or art, and it's like well balanced with the other pieces of who they are, they have higher recovery capital, less depression, less anxiety, and higher satisfaction with life than people who have a passion that kind of overtakes their identity and becomes an obsessive part of their life. I also found that people who had that more obsessive type of passion still had higher recovery capital than individuals who had no passion at all. So there were about 100 people who said that they didn't have a passion in their life, and they had kind of the lowest scores on everything, essentially. So it's just a new model that I was excited to try. I'm going to keep integrating it and seeing if it's showing up. But essentially what it says is that people in recovery, this can be a really important part of their process, is to find something, reconnect with something that's really important to them.
Awesome. Thanks. And we will hop over to Hannah now. Hannah Slick. We have a couple of Hannahs today.
Hi. So I'm actually Alicia Worley.
Oh, thank you, Alicia.
You're good. I'm presenting on behalf of Dr. Hannah Slick because she is also stuck in travel limbo at the moment. But her paper and the paper of all these other lovely co-authors is exploring the research question of what are the interpersonal and intrapersonal factors that support and impede recovery. And this question was explored through qualitative interviews from 24 adults who were receiving treatment at a consenting facility within the Midwest, most of which came from Missouri. And these participants completed a 1-month follow-up interview after using a mobile health intervention called UMatter, which is a mobile recovery app that our team has developed. And these participants were asked questions about the intervention and then just general questions about their recovery experiences. And the implications from the analysis of these interviews were, in terms of providers, were greater discussions and planning for independence with their clients, while also being mindful of a person's fear of considering future setbacks. It was also noted that providers should ask more about the purpose and nature of clients' relationships beyond just assessing for the presence or absence of supports in general. And also, there was a need for providers to develop more opportunities for loved ones to receive psychoeducation about substance use and recovery, where they can also receive support. And in terms of policy, there was a request for greater advocacy for funding to enhance recovery capital, such as permanent housing and other aspects of a person's recovery capital outside of just your standard traditional treatment or medication.
All right, wonderful. And now we move to Katie.
Hi, everyone. Our team recently published a study examining psychological safety as a key mechanism supporting recovery. Psychological safety refers to a shared sense of being accepted, valued, and able to take risks without fear of negative judgment. And while it's been extensively studied in workplaces and healthcare teams, it's rarely been examined in recovery communities where trust and belonging are essential. Now, the Phoenix is a nationwide sober active community offering free fitness, outdoor, and social events like CrossFit, climbing, and book clubs to anyone with at least 48 hours of sobriety. Now, the events are intentionally designed to create both physical and psychological safety with staff and volunteers, including peers, modeling support and inclusion. In our study, 204 Phoenix members who had participated for 3 months completed surveys assessing their perceived psychological safety and changes in recovery-related outcomes. We used structural equation modeling to test whether psychological safety mediated the relationship between attending events and these outcomes. And results showed that psychological safety did fully mediate the effects of attendance on hope, connection, and empowerment, which then predicted improvements in motivation to stay sober, mental health, and physical health. And attendance also had a direct positive effect on physical health. Outcomes went beyond simply showing up at events. It was feeling psychologically safe, welcomed, valued, and unjudged that made engagement transformative. These findings extend psychological safety beyond workplaces into community-based recovery, highlighting it as a foundation for human flourishing. When people feel safe to be themselves, they can take the vulnerable steps that fuel healing, growth, and community.
All right, and now we have a group of papers that Sharon will get us started off with.
Great, thank you. Hi, everybody. So our work was driven by the fact that the recovery needs of the Black population and the potential impact of racial disparities and pathways to recovery have not been examined. So our team conducted semi-structured interviews about recovery journeys with 37 Black individuals in Detroit who identified as in recovery from alcohol use disorders, and we partnered with the Detroit Recovery Project. We identified 4 overarching themes. First, delayed recovery initiation was common, largely due to systemic challenges and the lack of knowledge about recovery that resulted in the belief that recovery was not possible. Second, once initiating recovery, many people reported getting stuck in chronic early recovery due to relapse cycles that regularly involve system and individual challenges coupled with inadequate support. Third, most people use blended recovery pathways, some of which were common in the literature, formal treatment, mutual help, and some were more prevalent in Black communities such as religion and spirituality. And fourth, the facilitators of recovery varied by recovery stage. So participant stories emphasize the burdens experienced at personal, interpersonal, environmental, and societal levels. They directly connected these burdens with the difficult mission of achieving and sustaining recovery from alcohol problems. Some challenges in recovery pathways were common in the broader population, and some, such as the impact of racism, were unique to this low-income Black population. They also highlighted how culturally anchored resources and strong community assets support the difficult mission of initiating and sustaining recovery from alcohol use disorder. Our findings also stress the importance of trauma-informed care, as many types of trauma were common, and flexible recovery support structures that involve robust peer recovery services. And our future research is moving on to use these same interviews to look at the understanding of recovery itself, to see if current definitions of recovery also hold in this Black community. That's it. Thanks.
Move it on to Camille.
Hello, I just wanted to give a disclaimer before I get started that if you've experienced pregnancy or infant loss, I am going to reference those things when I talk about this paper. And so postpartum is defined as up to 1 year after pregnancy and includes people who are actively parenting and those who are in the postpartum period but have had their children removed or experienced pregnancy and early infant loss. We surveyed needs with multiple choice and open-ended questions with 100 women with past or present substance use disorder and asked them to report on any challenges they experienced during the postpartum period as an emerging adult. And we also asked them to share about aligned solutions to help inform services improvement. Of note, pregnancy and infant loss and child removal occurred among more than half of participants. And I think that that's really important to know because when we're thinking about supporting people in this period, we should be expecting to also support people who don't have a baby in their arms. And one participant shared after giving birth, there was only a chaplain. No one came to help me afterwards for the loss of the child or to assist me with my living child. The top challenges for postpartum emerging adults included anxiety and depressive symptoms, more than things like help for healthcare, SUD services, financial support also came up, and social support as well. And one participant shared, I wish that there had been a widely known young moms group that was positive and accepting, a place that was open often even just to sit and let the kids play and have people feel connected to. I think the worst part was feeling lost and disconnected, highlighting the need for informal social support. Participants also described solutions to destigmatize societal perceptions of postpartum emerging adults with SUD, as you can imagine, related to stigma of the experience of parenting with a substance use disorder, to provide mental health services that are responsive to social challenges, like not having social supports like family or friends to help when they needed things like childcare, to provide practical economic assistance for things like diapers that often are not provided by things like WIC or other social services, improve awareness of services, and support the formation of informal support networks. They also highlighted their resilience, saying that I have two beautiful children that are my whole world. I wouldn't trade a moment of hardship or suffering because I wouldn't have them today. And my children are the only thing that keeps me hopeful, strong, and determined to have and provide a better life for myself and my kids. And I think that this highlights really perfectly the opportunity that we have in the postpartum period to support people in recovery.
I love that. All right, we'll move to Hartley.
Hi there. I am going to tag team. I enjoyed that, Camille. Thank you. Mine is also about perinatal and reproductive time period for people in recovery. So we partnered with an academic. I'm from an academic institution, and then we partnered with several recovery community centers to develop a perinatal reproductive champion of health and harm reduction that could be housed in recovery community centers. And so we did a pilot study where they were directly working with people who were able to get pregnant, aged 18 to 45. And we recruited 28 participants who enrolled with the recovery community centers to receive specialized recovery coaching in addition to all of the great things that they were already receiving. The recovery coaches received an additional training that we created with the community with the idea of linking people to services earlier So if you're pregnant or postpartum, or a person who would like to become pregnant or would like to prevent a pregnancy, then we were trying to get you linked to some healthcare services in a way that you get the care that you deserve, regardless of where you are in your recovery trajectory. And we also supplied harm reduction items to try to encourage reach of primarily women of this age group, because it seemed to be, we know that there are a lot of people who are not comfortable seeking services in depending on their reproductive status. And so we were able to promote, we distributed monthly pregnancy tests. At the end, we were averaging 400 pregnancy tests a month, 230 emergency contraceptions, and 105 prenatal vitamins, because there were several women who were interested in becoming pregnant. And overall, of the 28 people we recruited, 81% of them had had an unintended pregnancy at some point in their life. They had had 131 lifetime pregnancies, so they were quite fertile. We improved the reach of the recovery community centers to reach women of reproductive age by 66% in the year that we did the implementation. And we had developed 9 new partnerships and referral sites specifically for women. And 25% of of the 28 participants were successfully linked to perinatal or reproductive health care. And just to make note that I think is a shout out to what we could be doing a better job of, especially on the healthcare side, is that 30% of the women that were in this group wanted to become pregnant, and they were rarely asked or rarely in spaces where anybody talked to them about preconception care and how to reach, how to navigate this, because they felt like they were being targeted for contraception a lot more than they were being targeted for healthy pregnancies. So that is it. Thank you so much.
Thanks. And jumping over to Nicole.
Hey everyone. So our team conducted qualitative research interviews with 25 young adults in OUD inpatient treatment. We asked them about their attitudes and their beliefs about family involvement in treatment and in recovery services, and their perspectives on family involvement in their own treatment. We found that young adults consistently reported that despite some challenging relationship dynamics, their families were really supportive and motivating. Young adults experienced their family members as being aligned on their treatment and recovery goals, and that also included medication for OUD treatment. They described their beliefs that family involvement is essential to treatment and to recovery. And they also talked about their preferences for family involvement in their current treatment. What was surprising was that even though young adults reported that they saw the value in family involvement in services and they wanted their families involved in their care, only a small number of young adults reported that their family members were actively engaged in service activities, like attending family sessions. Almost all young adults that we interviewed said that they would like their families to be more rather than less involved, and that their families were supportive in other ways, like visiting and providing essential items during their inpatient stay, like clothes and food. Our work really underscores that there's a real missed opportunity for involving families in young adult OUD treatment to improve retention and outcomes. And as a field, we have work to do in helping providers and helping agencies to be better equipped to systematically collaborate with families and engage them in treatment and recovery services.
Excellent. Our last grouping of papers here on policy and systems, we start with Sierra.
Right. So bringing people with lived experience and the community into research has gained a lot of traction in the substance use and recovery research field in general, but economic evaluation and health economics research has lagged a bit behind. So this study sought to help fill that gap. There was already a really pressing need for the cost effectiveness of peer recovery support services. So we teamed up with 2 recovery community centers, or RCCs, in Austin, Texas, Communities for Recovery and Recovery ATX. And we got detailed input from staff, which included mostly peer workers and people with lived experience, on both the analytic model for the cost effectiveness analysis and also on building out a free web-based cost effectiveness calculator. We also included a second piece to that calculator that estimates cost effectiveness of bystander naloxone distribution, which was based on a previous study and then modified with input from the RCCs. We met with the RCCs across 2 sessions, one to break down piece by piece those analytic models, and one to pre-test and make adjustments to the calculator. We had pilot funding from the Recovery Research Institute, but it was a limited budget. And despite that limitation, this calculator has been used hundreds of times, and we've presented it across dozens of different professional organizations, targeting organizations that provide peer recovery support services. So while this was a small pilot study, it provides a timely example of how those community voices can be a meaningful part of economic evaluation research and in the co-creation of tools that directly benefit those organizations on the front lines. And I've dropped a bunch of links for you in the chat, and feel free to reach out if you have any questions.
Thanks, Sierra. And Dennis.
Good afternoon. So I'm going to be talking about the recovery management checkup intervention, which has been was developed by Chestnut about 25 years ago, Chestnut Health Systems. And despite about 6 clinical trials at this point over 25 years, the model itself has not been disseminated into practice beyond some limited situations. So if you've never heard of it before, don't worry, we're trying to change that, and this study is the first step in it. So this is basically a linkage intervention that follows people through a chronic care model over time who have a substance use disorder to keep them engaged in treatment and sustain them in recovery over a minimum of 12 months, ideally, is what we want to deliver it for. Are immediately preceding this small feasibility study that I'm going to talk about, we completed a trial of recovery management checkups in primary care settings that was 4 FQHCs. We compared ESPER, screening, brief intervention, and referral to treatment, to ESPER plus RMC, and found that the recovery management checkup group was much more likely to get linked to treatment, stay in treatment, reduce substance use. All of the outcomes that we were looking at were much stronger in that group. So for this feasibility study, what we wanted to do was actually figure out, can an FQHC feasibly deliver this in practice? Because the intervention had only ever been delivered by folks working out of our research offices up until this point. We did a small condensed 30-day version of the intervention. We randomized only 16 patients to receive the intervention from an FQHC-based staff member versus one of our linkage managers who works in our office, who was already had familiarity delivering the model as part of research projects. And what we found was really encouraging. Over half of the patients screened, that we looked at had some form of substance use risk, but we only ended up enrolling 16. Like I said, one of our goals was to understand, could we actually identify folks in practice without an expert model as part of delivering RMC? Among those referred to the intervention, most completed their meetings, and the FQHC linkage manager actually, in a lot of ways, outperformed the research staff. Again, this might have to do with the fact that they were able to see people face to face versus we were delivering it out of our office remotely for individuals. But we wanted to see that they could at least do that in parallel with each other. And one of the things that was really key was we were looking at a lot of implementation related barriers and facilitators. And what we found was that there were some barriers that really stood out. The electronic health record was a barrier. Standardized assessments could be disruptive within the context of delivering them within care, because what that means is that without a researcher collecting that data, the actual linkage manager has to flip back and forth between conducting a motivational interview versus just collecting close-ended questions. That can be very difficult to do. And there is currently no reimbursement pathway for this kind of linkage, which is probably the biggest barrier we're facing. But in the end, we found that it was feasible, at least to deliver within practice, which has set us up for what we're trying to move towards now, which is a hybrid implementation effectiveness trial to see if we can actually compare the services delivered by FQHC linkage managers and then randomize them to either receive it from the FQHC or receive it from linkage managers working out of our office. That's it.
All right, and I'll jump in for Peter. Peter works for the federal government, and as some of you might be aware, not really functioning right now, or it's shut down, whatever. Anyway, I would highly recommend folks read this paper. It's a 30 agency working group. This is sort of a mini review of all the work that was done, kind of looking at the near term recovery research priorities, and some of the stuff that is incredibly important to me when reading this paper is, it's going from this idea of like, do recovery support services work, to what does the recovery ecosystem look like? What is the larger picture? We know we have a lot of evidence for these individual interventions and these services. What does the big picture look like? Also talked a lot about centering the voices of people with lived and living experiences, not just in an advisory role, but as partners within the research project itself, right? Again, look at Jeep and Path that Dennis is doing, some other stuff like that. But again, I would highly recommend reading this, looking for the path forward. There was also, we had some discussion earlier about issues we still face in 2025 of stigma. That was also a big recommendation in this paper. We got to figure out how to not be jerks, right? Yeah, and I'm going to go ahead and wrap up too. We have 4 minutes left. That was a lot of work, y'all. And Danielle, if you want to stop sharing the screen. Like I said, this is our, like Ashley said at the beginning, this is our 30th CoARS showcase, and it has just been an incredible honor to be able to work with everybody to try and facilitate this every month. This has been 3 years of just being a part of an incredible community of practice, right? I've been in some fields where there's this sort of competitiveness and protectiveness and all of that. I haven't found any of that in this room right here. So, I want to say, for those of you that this is your first time joining us, we do this every month. And, usually it's a bit more in-depth into individual projects, individual papers, and we help each other do the science because we just can't do this alone. And I would not be the researcher I am without you guys. And I'm going to shut up before I get too misty. I just want to say thank you.
All right. Well, with that wraps us up for today. Like I said, this was very exciting. We will be sending the link for the video we've recorded. We will send that out to everyone who is on the invite, or if you aren't on the invite, then pop your email in the chat and we'll make sure you become part of that. If you have thoughts for any future showcases, including more in-depth dives into some of the papers you heard about today, and you want to give your vote to that, then put that in the chat or send us an email. And hopefully you've connected with folks, and that you've all gotten links to papers that you want to take a little bit deeper dive and look into and read. And we appreciate everyone being here today and hope to see you next month.
Thank you.
Thanks, everyone.